Welcome, everyone. My name is Brooks Roach. I am a diabetes education specialist with Diabetes Canada. My pronouns are he and him, and I'd like to begin by acknowledging that I'm joining this webinar from the traditional and unceded territory of the Mi'kmaq people. Wherever you're joining or watching from, I'd like us to please express gratitude for the land on which we live and acknowledge all past inhabitants of what we now call Canada. I am here today with some wonderful guests to talk about how those of us living with diabetes or pre-diabetes can find support for diabetic foot ulcers to decrease the incidence of amputations and practice general foot care to prevent or best manage complications. This webinar is a very special collaboration between Wounds Canada, an organization dedicated to the advancement of wound prevention and management for all Canadians, and Diabetes Canada, which is committed to helping people with diabetes live healthy lives while working to find a cure. So today, I'm very pleased to introduce a few wonderful guests, as mentioned, Dr. Zaina Albalawi, who is an endocrinologist at Eastern Health and a clinical assistant professor at Memorial University of Newfoundland in St. John's. We also have Dr. Robyn Evans, who is the medical director of the Wound Healing Clinic at Women's College Hospital. Welcome, Robyn. We have Matt Anderson, who has lived experience with diabetic foot ulcers. Welcome, Matt. And we have Crystal McCallum, Director of Education at Wounds Canada. So welcome and thank you to you all.
Happy to be here.
Our experts will be answering some key questions that we've been hearing from our community and that our experts have been hearing from their patients. We're very pleased to present the patient's perspective as well from Matt at this webinar. We will also be taking questions from you, our viewers. So some questions have already been submitted and you can ask by typing in the Q&A or the comments. So let's dive right into it. First question is going to be presented to Dr. Albalawi. We'll start with you. Can you walk us through the burden of peripheral neuropathy, diabetic foot ulcers, and the resulting amputations on patients and on our healthcare system?
Absolutely. And I just want to thank this great collaboration, first of all, between Diabetes Canada and Wounds Canada, which have been leaders in trying to educate and reduce those complications with diabetes. So yeah, so this is great. We'll set the stage first and draw that big framework of why we're here today and why it's important to speak about foot care. And I am going to be sharing numbers, but I'm reminded today from one of my patients where I had a visit this morning telling me that I'm more than a number. And it really resonated with me as I was kind of prepping for today. And so as I say those numbers, I'd like us to really think beyond the numbers and think about the lived experience of people with this. And it looks very different for everybody. So I am going to start with peripheral neuropathy, which is one of the causes one of the underlying causes of diabetic foot complications. And where, it's one of the microvascular complications where nerves are impacted due to multiple factors relating to diabetes. And, putting that into context, about 50% of people with diabetes will experience peripheral neuropathy. And in addition to other risk factors like circulation, deformities, and other factors, ulcers may result secondary to that. And so if we think about, how common are ulcers in people with diabetes, that number ranges between 15 to 25%. And it's still thought to be an underestimate because we don't really have good tools to capture all that. So, putting that again in perspective of people with diabetes in Canada and the prevalence of that, once somebody has experienced an ulcer and skin breakdown, even once it heals, they're not really in the safe. And we know now that the recurrence of those ulcers are quite high. So a year after a wound heals, the chance or the risk of recurrence is about 40%. So we think about it in the framework of cancer that once it's healed, there still needs to be that active surveillance and interventions to reduce that. And we have some new data to show that once ulcers do occur, it's not simply a wound that's healed, end of the story, but there have been associations with mortality as well. So 5-year mortality once somebody has experienced a diabetic foot ulcer is about 30.5%. So we've talked about peripheral neuropathy, diabetic foot ulcers, and one of the most feared complications, from patients is amputations. And literature has shown that, it's no surprise people fear that more than death. with the disability, the impaired quality of life that comes with it, as well as the big changes. And so we know once somebody has had an amputation, the risk of death following that 3 years after an amputation is about 71%. Now that's quite a staggering number. And, you know, we add a layer to that, looking at the burden of diabetic foot complications is the disparity. Those complications are not equal among people with diabetes. We find people of different race, indigenous status, socioeconomic status, rural populations, those added layers, we see those numbers magnified even further. So I think putting that into perspective, it's a serious issue. Diabetes contributes to a number of different complications. This is not to take away from any of the others, but about 70% of amputations are contributed by diabetes. And not to mention the impaired quality of life that comes with that. And then from a patient perspective, significant impairment of quality of life. I'm leaving the healthcare system till the end because, you know, that is more of a system issue. And as healthcare providers, we're looking at sustainability, but I think it's an important issue to talk about as well. So the Gemini group in Ontario has done some elegant studies looking at what does it cost tax dollars and payers for this. And so if somebody comes in with a diabetic foot ulcers, the cost of a stay is about $22,754. And if an amputation happens because of those complications, that number jumps to $48,808 per stay. So we can see what a significant cost and burden it is, starting and most importantly at the individual level, but then also magnified at the system level. And so really, you know, until we have a cure for diabetes, the focus is to reduce the risk of those complications and support people with diabetes living healthy lives.
Thank you so much, Zaina, and I really appreciate the navigating that difference between individual and system level challenges. So thank you for setting that stage for us. Now we're going to kind of zoom in, and the next question that I'd like to ask is to Matt. I'm wondering if you could share with us a bit what it's like to live with these complications and your experience with that.
Once again, I'm happy to be here. I'm glad that I'll get to shed some light on this issue. I've been dealing with diabetic foot ulcers for a good 17 years. My first foot ulcer started on my big toe, my right foot, from a pair of golf shoes. I used to play 100 rounds a year. I don't play golf anymore. I've basically, it started out as I was younger. I was 30 at the time, and I was 30 years younger than anybody that was in the clinic whatsoever. And that's what I kept seeing. I'm very young to have this. I'm very young to have this. And there was a lot of denial. I didn't want to listen. It was my own fault in the sense, like my job, I walked on concrete all the time. I wore steel toe boots. I didn't have correct offloading. I didn't really know anything about it. I got diabetes when I was 22, and my doctor told me, "You're fat, lose weight, your diabetes will go away." Sent me to a nutritionist, and that was that, and see you later. So, I mean, my experience with diabetic foot ulcers, I basically became a compliant patient through maturity and through experience, because, I mean, over the last 17 years, I've probably lost about 6 years out of work. I've been on disability. I've had problem with disability insurance. I've had to fight battles because you can't see a diabetic ulcer. I don't limp. If you're just looking at me, but I have a deformed left foot. I've had 6 surgeries on my left foot. I've got 8 toes. But I refuse to give up. Like my last surgery, Dr. Lau, who's unbelievable in Toronto Western Hospital, said to me, he goes, "Matt, you're like, I've always been a big guy. So Matt, you're 500 pounds. They don't give steel legs to a guys that 500 pounds. They give steel chairs." And that was kind of started me on a pathway where I'm kind of saving my life. I'm down about 150 pounds in the last 10 months. But it totally encapsulates everything you do in your life, having a diabetic foot ulcer, from what you do with your family, from what your family has to deal with you, from like just a simple thing of having a shower in the morning. I can't get my foot wet. So I have a stool in the shower. I have to put my leg out of the shower so that leg doesn't get wet. And then I've got to spend an hour changing my own dressing every single day. Like, so getting ready to go do anything in the morning takes me an hour and a half, whereas it would take you 10 minutes. You know what I mean? So just little examples. And it just, I wasn't compliant at the start of all this stuff. I fought tooth and nail against the doctors and everything like that. And then finally I started to advocate for myself, and I wanted consistency in my healthcare. So I started seeing Dr. Evans and Dr. Evans only with regards to my foot care. And then she put me in the right frame of mind and with the right surgeons, and they're about prevention. They're not about amputation. And so that's the right spot. But it took me a long time to get to that spot. The first chiropodist I ever went to when I had an ulcer told me to soak my foot in Epsom salts for an hour every day. And all that did was wear away the joint, and that toe was gone in a year and a half. And so it's like, it's education, because there's different things. And I'm from Durham region, but I go, all my foot care and is in Toronto, because their approach to it is much different. Different regions have different approaches to this, right? So there's a lot, like, I mean, I could talk for 2 hours based on everything that you have to deal with, but just to start off, and it's just my relationship with my doctors, and my orthotist and my pharmacist, and my advocating for myself, and not taking, I'm going to amputate your foot as the be all and end all answer from some doctors that say that. That just leads me down to this point where I just want to have people to know exactly how difficult it is. I told you I was a talker. I'm sorry.
Nothing to be sorry about, Matt. I'd like to say thanks on behalf of everyone on this call, but also everyone watching. It means a lot to hear you share your story, and to I've lived with type 1 diabetes for 20 years, and I can relate to some challenges, but it's incredibly helpful to hear your take living day after day with these challenges, and the learning and growth that you've done to take a more active role in how you're sort of pushing back. It's honestly very inspiring to hear that.
Well, thank you. I appreciate it. And that's what it is too. Like I said, I'm the youngest guy in the waiting room at the Women's College Hospital Dermatology Day Clinic and everything like that. I'm the youngest guy at all times. And if I see a younger person come in to that waiting room, I know exactly where they're going. I know exactly what they're going to come out with. They're going to come out with an air cast, but there's no one there to tell them. There's no one there to tell them if you don't wear that air cast until your ulcer is healed, or if you don't offload that wound until your ulcer is healed, you're just going to do damage to yourself. So, I mean, I don't want to be nosy to some people, but I can tell people that I can approach, and I've approached people to say, hey, this is what you're going to go, this is the road you're going to go down with this. Don't take this lightly, because I did the first couple that I had. And so it's like my ulcer story is a tale of, like, it's been 17 years, and for 7, it's been me taking care of myself. And for 8, it was just, what am I going to do? So the problem is people, especially at my age, like I'm 47, I've been dealing with this since I was 30. The average age of people in the waiting room at the clinics are over 60. So maybe I just, you know what I mean? I want to work harder towards it, but it's difficult when you're young.
Yeah, 100%. And I think it's really clear to those listening that you must have an impact on those you speak with, Matt. And I think you point to an interesting side of this, this lived reality, which is developing trust and developing a strong relationship with a care provider. And that's my version of a segue to say that our next question is to Dr. Evans, who is, Matt, your care provider. And I wonder if the two of you can speak a little bit about your experiences both treating and advising those living with complications for Dr. Evans, but also, what that's been like on a one-to-one scale.
Okay, well, I thank you very much, everybody who's spoken already, and Matt, for all those that chat you've given us all. It's very eye-opening. I'm very lucky to work at a multidisciplinary clinic, and we have expert chiropodists and nurses, and we really work as a team, and I'm sure Matt would agree, and he's been on the receiving end of a lot of care from our chiropodists who have made a major impact for Matt as well. I mean, I really like the work I do there. I really feel like it's impactful for patients. They come in quite worried about amputations, and I think we do manage to change the care path. And it's great work to do. Over the last 10 years, though, thinking back about all the things that I think happen at the clinic, I think the biggest thing is that I think patients present a little bit late. Unfortunately, by the time we get them, they've had this diabetic ulcer for quite a while, and the complications that Zaina described occur quite readily. So I think we hope we could do a better job with that. And then I think I want to echo what Matt said about managing these diabetic foot ulcers is the whole concept of offloading. This is something we're asking patients to do, wear a device that's not necessarily attractive. We're asking them to limit their walking, changing their activities of daily living completely, and they're not particularly feeling this ulcer. So it's a real process to gain the trust with the patients and to impart this knowledge about offloading. At the beginning of the program, and I usually put it to patients now, is that, we need to go big at the beginning, do everything we can to get rid of this ulcer to start. Offloading is key. So we get rid of this ulcer in sort of weeks rather than seasons. And over time, I think we mostly do get buy-in, but I think it's the hardest part about dealing with it. And I think that's what Matt has struggled with all these years. And then in those that we do heal ulcers, and I think it's quite a lot, the biggest issue then is ongoing surveillance and where these patients go to after that, how we manage the patients in the system. And we have great chiropodists and podiatrists in the community, but there's a financial burden to this, and patients, it's not always feasible to be able to manage that. So discharge is sometimes a difficult process from our clinic. People feel quite stranded when we say, you don't need to come back again. That's not music to their ears sometimes for many. And then we have the whole issue regarding offloading itself, like the funding for that. And in Ontario, we've been very fortunate from the government to get funding for some removable cast walkers, et cetera. But going forward beyond that, there's a bit of a glitch in the system, and that's a difficult time. So, working with Matt has been great, and we've had a really good positive relationship over the years. But I think, there's always things you can look back on and maybe think, Matt, what do you think would have been more impactful to hear at the beginning of your journey back, years ago? Is there something that could have been done better or quicker?
Well, no, like I would have to say my maturity, you can't look back. Like I would have to say my maturity level is increased. Like when I got diabetes, I was young. I was 21. I was doing everything that a 21-year-old kid would do. I didn't take it seriously. Until I had a problem. So that's on me. I didn't understand it. I was like, okay, fine. I have diabetes, lose weight, it'll be fine. I listened to what the doctor said to me, and I fluctuated all my life. So, but the point so it's not as if you can't go back and change time, but you can go back and change your attitude. And my attitude was horrible when I first had it. I was single at the time. I owned my own house. I needed to work. I couldn't go off work despite I had this hole in my foot. It didn't hurt. And then the only way an ulcer hurts is if you get an infection. And I know exactly through the years, however many infections I've had in my foot, I know the exact signs, where it's going to hurt, when my infection's coming, and what antibiotic I need to take. So in order to avoid IV antibiotics. And I'm pretty good with it. I think Dr. Evans can attest that I'm pretty good at knowing when my body is telling me I'm getting an infection. But it's honestly about, I couldn't live without my orthotist, Melanie, from Back to Feet. I could not live without her. She is the one person that keeps me walking all the time. And whether it's adjusting my orthotics monthly, whether I wear an AFO on my left foot, which is an orthotic and a brace to keep my ankle stable, whether it's that, like I'm as soon as I have a problem at the clinic and Dr. Evans has to see me, my next call is my orthotist. And so then we go and try and offload. But it's like you rob Peter to pay Paul when you offload. And so, like I'm 6'5", right? So I'm very tall and I'm top heavy. So It's very hard to offload. You can't change your gait no matter what you try and do. Sometimes orthopedic shoes don't work whatsoever, and it's tough to get them because some benefits companies don't cover them. And I have 2 pairs of orthopedic shoes worth $5,000 collecting dust upstairs because they didn't work. When I had to wear an air cast for my last ulcer, I had to get my air cast modified by my orthotist because it wasn't offloading correctly, and I was too big for the air cast, and I was bottoming out in the air cast. So it's a lot of diligence between me and saying, okay, let's try this, to the point where, and then I'll pass that information off with Dr. Evans, and we'll work together to try and fix the issues. But it's an ongoing thing. I have to if my wife says let's go for a long walk on the beach, I'm going to say sorry, honey, I can't go because I can't take my shoes off, and I can't walk in sand because it's not flat ground, and all that sort of stuff. So it's a snowball effect if you don't. And now that I've been kind of managing it, my quality of life's a little better because my sugars have been better. I'm a more compliant patient. However, there's still all these things that add up to your day, and because it's not seen, and because I can fake through an ulcer if I'm sick. I've had so many before, but only people that really truly know you're in pain and when you're in pain. So again,
I think Matt, one of the things you've highlighted in this is the fact that you really need to know how to navigate the system, who you need to know. And I think early on in, a person's journey with an ulcer, I think that's one of the things that I think we probably could do better at is knowing where to send people, having the resources of where to send people. And of course, obviously prevention is really the key in all of this, and making, more aspects of care readily available to people with diabetes and ulcerations.
But just to add to that, though, it's the mindset of the doctor that you're dealing with as well from a patient perspective. Like, I've seen so many surgeons in my life with regards to this, and I know the first surgeon is always the intern, and they look at me and say, you're fat, you're overweight, we're going to have to cut off your leg. And I'm like, just come and see me when the real guy that's going to cut open my foot, and then we'll talk about it. And it's like, so then you get a different approach. So I worry about younger doctors coming into the system with an archaic 70-year-old doctors look at things. Well, we have to do this. We have to amputate his leg. No, we don't. Like, you could have amputated my leg 10 times if I had the wrong doctor. But I have the right doctors and the right people that care. And so they're all about saving my foot. And so if they're all about saving my foot, I have to be about saving my foot too. So that's where you get on that page. But there's the lack of empathy towards a patient when you just take a look and take a snapshot of what you're looking at. Like, cause me, oh my God, you're overweight, you're diabetic, you used to smoke, blah, 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 all this stuff. You know what I mean? It's easy to take a picture, but I found the more that I talk to medical professionals and educate myself on what I'm dealing with and everything like that, they'll sit and give me the time of day a lot more. So in that, but not every patient can do that. Not every patient understands that. Push for it and you'll get the help you need.
Yeah, I think there's I think we really need to educate both patients and early on. Patient education is really important, and it all just comes back to the preventative piece, and we wouldn't be going down this road if we had really good preventative care, I think. But thanks very much, Matt. I think that really outlines the whole system.
Yeah, thanks so much, both of you. It's fascinating to see a bit of patient-doctor dialogue. And we're very pleased, again, as mentioned, to be partnering with Wounds Canada, and we have Crystal McCallum as a guest. And my next question is for you, Crystal. And I'm wondering, if I'm a viewer who lives with diabetes, if I live with foot complications, or if I care for someone who lives with this, what resources or programs are available through Wounds Canada?
That's a great question, Brooks. And I think I've got a little slide prepared. Is it okay if I share that with your audience?
Go right ahead.
Sure. All right. So Wounds Canada has a number of resources for people with and at risk for diabetes-related foot complications and for their caregivers. In response to the COVID-19 pandemic, Wounds Canada created a series of 10 resource documents to empower people living with or at risk for wounds and their caregivers to prevent and care for the wounds. Known as the Care at Home series, these easy-to-read educational resources have been downloaded 27,000 times since their launch last year. 2 of the Care at Home series documents may be of particular interest to your audience: Safe Foot Care if you have diabetes, and Diabetic Foot Complications, one is in an emergency. These resources, which are freely downloadable from the Wounds Canada website, so www.woundscanada.ca, provide practical guidance on preventing and identifying diabetes-related foot complications, including, amongst other things, adopting a healthy lifestyle, performing daily foot inspections and foot care, performing safe nail care, and selecting shoes that fit. French language translations of these documents will be available on the Wounds Canada website shortly. In addition, access to Diabetes Healthy Feet and You resources can be obtained through the Wounds Canada website. Offered by select LHINs or local health integration networks in Ontario, the Diabetes Healthy Feet and You program consists of a 2.5-hour interactive workshop or 2 1.5-hour interactive virtual sessions that empower people living with diabetes and their caregivers with the knowledge and skills needed to prevent diabetes-related foot complications. Many of the resources associated with this program have been translated into 16 languages and include, amongst others, finding the proper shoe fit, foot examinations for people with diabetes, questions to ask your healthcare professional. Your audience can also sign up to receive monthly foot care tips sent directly to their inbox. And finally, Wounds Canada recently partnered with Queen's University to create a diabetic foot care Facebook study group. This study aims to determine the feasibility of a Facebook group-based program to support adults with diabetes in their foot self-care practices and the prevention of foot ulcers. If anyone listening today is interested in joining this private community to learn foot care strategies and gain motivation to better care for their feet, prevent ulcers, and live a healthy life, visit the Wounds Canada website for more details. Now, participants in this study group must be 18 years of age or older, have a diagnosis of diabetes, be proficient in the English language, have access to the internet, and have an active Facebook account or be willing to create one. Wounds Canada also has some resources for healthcare professionals as well, which you see on this screen. And what's most exciting about these resources is the upcoming Wounds Canada Limb Preservation Symposium, which is taking place next Friday, May the 28th. This full-day event, virtual event, has been accredited by the Canadian Society for Vascular Surgery and features some of Canada's top experts in diabetes, foot-related complications, and limb preservation. So I encourage any healthcare providers to consider joining this event next week. And certainly members of the public are welcome to join as well.
Thank you very much, Crystal. I really appreciate the diversity of programs and resources that you've been developing. And you know, there was a line that said, "When is it an emergency?" which I found really encapsulates some of what we've been talking about, which it is by definition a slow process. So it can be very important to recognize those warning signs that may creep up on a person. So thank you. Going to pass the next question to Dr. Albalawi. And the question is, if you could just share some best practices and strategies for folks living with diabetes to prevent complications, to advocate for themselves with their healthcare providers, and just to live well with foot complications.
Lovely, and thanks for that question. I think this is the flip side of the story. This is the bright light at the end of the tunnel, and this brings me the most joy to speak about. So I'm happy to share this with everybody. And I just want to really echo what Crystal said and Wounds Canada. You know, when I moved to Newfoundland, we did have a multidisciplinary team in Alberta working there, and moving over here, I've seen firsthand the impact of the educational programs that are honestly, you know, top notch, not only for providing education, but training people to train others. And I can say probably single-handedly, Wounds Canada, you have the credit for reducing the risk of amputations across. So I just want to applaud you for all that great work. And I think Canada is very fortunate to have you. So for prevention, I think I'm going to start with key principles. And this is pretty much standard across all diabetes and foot care prevention guidelines in Canada, the US, and the International Working Group for the Diabetic Foot. So 5 principles to reduce the risk. And we know from the literature that up to 80% of ulcers and amputations are preventable. And I usually start off right there for patients with my first line on education. And just to have that empowerment to know that there are things within our reach that we can do. And again, I think I'll just touch on what you mentioned, Brooks, about the system and individual level. We should not be gaslighting and having patients carry the burden of all the care. I think we need to be very clear and acknowledge the gaps in our healthcare system. And so it saddened me a bit, Matt, to hear about kind of your sense of failure or so on, but I think it's a lot to bear on one person. There are system aspects, and us as healthcare providers, we have responsibility in terms of focusing research on primary prevention, which is lacking. Healthcare policy advocates have a role, nonprofit organizations, and politicians as well, to put this at the frontier. So it's just broader than the individual, and I'd like to make sure I highlight that. So 5 key principles for prevention. The first one is going to be finding those people with neuropathy who are at risk. So screening, number 1. So be sure to have a foot exam once a year at minimum for everybody with diabetes, and 5 years after people have type 1, because we can't really manage or address what we don't know about. And the risk category, which Wounds Canada again provides great resources, low, moderate, high, or very high. It's kind of like the traffic light system. And that's what I usually communicate to people. You're at low risk, next exam is in 1 year, versus moderate versus high, and we have action plans. So I would encourage people to be aware from an individual level that, this is standard of care. If you haven't had it, bring it up at your visit. The second thing is going to be regular inspection, and that's both healthcare provider system as well as individual level, where people can inspect their feet daily. And if they find any of the red flags, or what we call pre-ulcerative lesions, so calluses, blisters, areas of friction, increased temperature, or nail changes, those need to be addressed early on. And there are, of course, so many challenges with inspection with people with diabetes and other comorbidities. So, there are always certain tricks that we can talk about on how to do it, or maybe involve health family or a podiatrist or a wound nurse or a diabetes educator for that piece. And then third is education. And I think, I don't need to speak more about that. Matt highlighted quite a bit, as well as Dr. Evans and Crystal, about the importance of education and making it very clear of what we're recommending, why we're recommending it, and what are the outcomes that we're aspiring for. And education spans the spectrum of individuals, so people living with diabetes, healthcare providers, family members as well. And I think that's a key factor. So that takes us to our 4th key principle in prevention, and that's going to be footwear. So 2 key things over here: routine wearing of footwear and appropriate footwear. And I think you've heard as well firsthand about the orthotist and the role of whether it's casting for offloading or even for reducing the risk of complications, the role of that. And I echo, and I will say it here again, I don't think they're appreciated or understood in the paradigm of foot care. Podiatrists are cornerstone to foot care prevention. They are the heart and soul. And, I was guilty in understanding that early on. And I think we now have models of podiatry or podiatry-like skills that are key for this. And I think we need to advocate as well for broad national coverage of podiatrists, chiropody across the country. That's a big barrier. And I think their skills are very undervalued, and they have a very, very important role to play. And that takes us to the 5th one, which really ties everything together. And it's timely management of either early signs or actual ulcers. So just like heart attacks, where time is tissue, and similar with a stroke, time is also tissue when it comes to feet. So sitting on an infection, sitting on a hot foot or a swollen foot is costly. And I think, Matt, I think if somebody's looking for recruitment for foot care, I always used to joke in my multidisciplinary clinic, people are very knowledgeable once you actually are able to provide them and have the resources to provide a multidisciplinary clinic. They know when they need to come in earlier. They know the early signs, and we need to listen. So timely access to care, and that spans heavily on a system perspective where we need to have clear pathways. I think Alberta has done a wonderful job in leading that work to unify care, so that whether somebody is in the Northwest Territories or in a rural area versus urban area, if they present with those red flags, they move through the system regardless of where they are and where they present. So that's really kind of a system level. And I know a number of wonderful researchers who are working on trying to put a case forward to try to get fundings and having that sustainably integrated into our healthcare systems at a national level. So those are the 5 principles. I'll just briefly kind of go over them. So we said screening, regular inspection, education, appropriate and routine wearing of footwear, and then timely treatment. And you can see how all that fits in with what Dr. Evans mentioned within a multidisciplinary system. And that is really the ideal, what we aim for. We realize there are resources and you know, this can look different, especially in the COVID era. But we think about the multidisciplinary in its broad and expansive view where, yes, you may not have everybody in that one center, but our community is broader, and you may have a podiatrist in your community that you can access, a wound nurse. I know we have a number of champions of care who try to leverage and bring that forward. So Wounds Canada, again, leverages and is creating a resource. And I encourage everybody, you know, if you know of a foot care center or expertise in your community, there's a website where you can email Wounds Canada and add it to the list. It's by province and by region. And I think we can all populate that and have that as a one-point access for everybody across the country. And I think, you know, your point, Brooks, kind of about, you know, strategies for people and really to advocate for themselves and to live well. I think at the end, the key message is, you know, broad picture and just zooming out, improving quality of life and reducing the risk of complications through an individualized care pattern that takes into account people's values is really key. And I'll just share a story of one of my patients with chronic diabetic foot ulcers, where, you know, I was asking him, you know, how are you doing? And he was like, well, you know, I'm starting ball dancing. My wife always wanted to. And my immediate thought was like, oh no, your feet, what shoes are you wearing? And I didn't say that out loud, but I said, oh, that's great, you know. And it took me a moment just to think, okay, wait, I had to process. This is incredibly important for him, for his relationship, for his life. And how are we going to support him? I'm not going to kind of just blurt out, you know, the 1, 2, 3, 4 steps that need to be done. So I said, okay, so it looks like we'll need to bring you in a little bit earlier to manage those calluses. He's like, yeah, do you think I can come in? Because the clinic was packed. I'm like, you know, let's do this. So sometimes we need to know what's important. Well, not sometimes, we always need to know what's important to people and what their values are. And then with our knowledge about the system and the prevention strategies to try to work around with the broader picture of still reducing the risk of complications, but also improving quality of life. And at the same time, individualizing it to align with people's values and what's important to them, which will continuously change.
Thank you, Dr. Albalawi. That's a really beautiful example of starting with a person's value and building back up to a plan of care from there. I think there's a lot of lessons that we can take from that. So thank you for sharing. Before we open up to questions, I'm seeing a few questions that have come in the chat. I'd just like to briefly touch on how Diabetes Canada is helping support people with diabetes as it relates to foot care. So one of our 2021 advocacy priorities is to push for provinces and territories to fund amputation prevention and limb preservation devices and to introduce comprehensive strategies that include screening, education, and resource budgets. This is also supported by the continued push to implement Diabetes 360, which is gaining a lot of momentum recently, a national framework that would raise the quality of care for all Canadians living with diabetes, and that includes specific investments into foot care. So for those of you who are looking for resources that are specific to folks living with diabetes, we have a number of resources on our website, diabetes.ca, and our social media, which is Diabetes Canada. Crystal, do you have any information on the ongoing work from Wounds Canada?
Sure. At Wounds Canada, our mission is to advance wound prevention and care for Canadians. And we are working towards this goal by supporting research, professional and patient wound education, evidence-based best practice and national standards, as well as advocacy. Currently, we're working with governments to provide better access to wound education, resources, and supports using a population health approach that promotes both downstream and upstream interventions. For those interested in more information, I encourage them to check out the Wounds Canada website at www.woundscanada.ca.
Thank you, Crystal. So we're going to move to a few questions that have been submitted. So first of all, thank you to everyone for submitting your questions. You have a great panel of experts that can probably give you a hand here. First one is from a viewer that has a crack in their heel and just wants to take a preventative approach. What's the best first step?
Moisturize.
Yeah, I think that's a good point to moisturize. Always look at the footwear, the moisturization, and sort of a conversation with the patient about what causes the dryness of the foot and how it's related to diabetes. So ensuring blood sugars are good, foot care is good, and appropriate instruction on how to moisturize that foot and protect it. And also to be very diligent about watching for signs of it deteriorating or getting any worse, so that if there is anything happening or signs of infection, that can be caught very quickly.
Next question is wearing socks or protective footwear recommended if you already have a diabetic foot ulcer?
Is wearing socks or?
Socks or protective footwear recommended if you have diabetic foot ulcer. So I think this, go ahead, Robyn.
So generally, in general, for anybody with a diabetic foot ulcer, we recommend offload all the time, and that includes inside the house. And I sort of tell patients, whenever your foot's on the ground, whether it be inside or outside, it needs to be in a protective footwear that has been approved by the person who's managing your ulcer care. So I would talk with a chiropodist or the physician, whoever's managing that is the best advice.
And I'd like to add to that, Robyn, around socks. So cotton socks are great, without seams even better, and light colored is most preferred. And the reason we suggest light colored cotton socks is so that if your foot does bleed or your dressing leaks through, you can see that. It's a visual indicator on that sock that something is not right.
Great tip. Thank you, Crystal. We have a question that's Ontario specific. So it's, does ODSP cover for orthotics with a diabetic patient on insulin?
There is some funding for orthotics for people with diabetes in Ontario, but the footwear itself is not covered by ODSP. Removable cast walkers are, and total contact casts, and some of the other types of shoes that are interim measures are, but going forward in terms of shoes, no, but some of the orthotics, yes.
Okay. Thank you. Next one has to do with identifying an ulcer. So how does someone know if a sore is an ulcer? Is there a line that makes that definition clear?
Can I throw something in there?
Sure.
Basically, if you see something on your foot, if it's like redness or heat or anything like that, don't touch it. Go to your doctor right away, whatsoever. Don't pick at it. Don't pull skin away. Don't do anything, because you're just going to wreck. You're going to make it worse by addressing it yourself. So you see any sort of redness, any sort of fatigue, notice that your blood sugars are rising whatsoever, and you take one look at your foot, that's exactly what the problem is. So you need to go get it addressed, but don't ever touch it yourself, ever, like ever. Take it from someone who's done it. It's not smart.
Thanks, Matt.
Yeah.
But I would say, to add to that, is a lot of people will have pre-ulcerative lesions, like even just a small callus. And any callus is meaning that there is pressure in that area. And that's just your body's mechanism of defense, is to build a callus. And any kind of callus can be a pre-ulcerative lesion. So surprisingly enough, I've had patients come to the clinic and we just scrape off a little bit of that callus, and lo and behold, there's fluid under there and actually a direct passage to the bone. So I think all these pre-ulcerative lesions need to be taken seriously in patients with neuropathy and diabetic foot issues. Thank you very much.
The next question is also a bit geographically based, but Wounds Canada might have an answer for this one, and it's from an asker who lives in Brampton and would find it helpful if they could see a specialist in their area. Wondering about a link so that they could find someone by whether it's postal code or region.
Sure, I would encourage that person to log into the Wounds Canada website, so www.woundscanada.ca, and navigate to the clinic directory. And you'll see in the clinic directory, it's broken down by province. There's not a lot of wound clinics or specialty clinics in Canada, so it's not a giant list that you need to toggle through, but anyone who has identified that they do see wound patients or patients with diabetic foot-related complications will be listed there. Alternatively, in Ontario, and this is Ontario specific, you can also log into the Health Line. So it's thehealthline.ca. And it essentially is a Rolodex of healthcare services and support services in Ontario by geographic region. And you can use your postal code and enter it to find services close to you.
Okay, beautiful. Thank you very much. The next question is from someone who has very dry feet and they're cold 24/7. I know they're okay, but what can I get to apply to keep them hydrated? This person is type 1 diabetic.
Yeah, I mean, with peripheral neuropathy, altered temperature regulation in the feet is one of the symptoms, and the sign would be the dryness. So just knowing that that may be the underlying cause, and until we can cure that and change that, it would be symptomatic relief with what was mentioned previously about moisture. So in general, anything that provides moisture works, and that gives you results. Just make sure to dry between the toes to avoid any maceration of the skin there. And then the other thing is, regular moisturizing to get the maximum out of it, doing it after a shower, just to optimize that uptake and optimize the uptake there. If people are having challenges despite regular routines with moisturizing those areas, another option is choosing a product that has something called, can you help me out, Robyn? Was it urea or?
It's, well, there's Uramol or lac hydrin, it has it as well, but yeah, any one of those.
Perfect. So the product itself, just because it can help moisturize additionally, that medical component in the cream would help. It is off the shelf, I should say, to maximize hydration.
And I'd like to add, generally speaking, when you're choosing a moisturizer, it's important to choose something ideally that does not have a scent. So something unscented and something that is doesn't contain a lot of known allergens to the skin, like lanolin, for example. And when in doubt, ask your pharmacist. Community pharmacists can make some excellent recommendations on appropriate cream or moisturizing options for you.
The next question is from a person who has Charcot, CHARCOT. They're wondering if they are more susceptible to ulcers as a result.
Absolutely. For everybody who doesn't know what Charcot is, it's caused by neuropathy, and that neuropathy in some people can lead to sort of microfractures of the bone, leaving a deformity of the foot, most commonly in the midfoot, so at the arch, and sometimes you'll see it as a dropped arch. And of course, this then provides a prominence in the foot, and it's susceptible to pressure, and for that reason alone, and the loss of sensation, ulcers can develop and go down a very difficult road and many complications. So with Charcot foot, customized or footwear is highly recommended, as well as they become a high-risk patient and should be followed very carefully. And surprisingly, you do need to have the footwear adjusted very regularly because gait changes and the foot does change over time. So it is a lifelong process of managing this.
We have a question from someone who has been type 1 diabetic since September 2020, so a relatively new diagnosis. They've not yet seen a podiatrist. They have no issues now, but don't want any either. Pretty reasonable request. Should they make an appointment?
So if they have type 1 diabetes, generally the recommendation from a guideline perspective is starting to screen for complications 5 years outside of the diagnosis, because you don't have, that is quite different than type 2. And so with that, we'll generally start screening at 5 years with a 10-gram monofilament to check for protective sensation, circulation, and so on. So I think, just these are the recommendations. However, if someone, we don't want to have things, I think, stem from fear and build anxiety and so on. So I think I just want to make sure that the facts are clear and the data. However, if they have other issues relating to their feet, for example, if they have deformities or bunions or they're noticing areas of pressure, absolutely, podiatrists will be helpful from a prevention perspective to do it, but that might not be directly related to your diabetes yet. If peripheral neuropathy develops down the road, that might be another layer, another reason to have frequent follow-up. And I'll just turn it over to Crystal, Robyn, or Matt if you have any other thoughts.
Go ahead,
Yeah.
Dr. Evans.
No, I totally agree with what's already been said. I don't really have anything else to add. I think that's quite complete.
A question regarding, does this person need to be referred to a diabetic foot clinic for corns and plantar's warts?
Are we talking about the same person who's just newly diagnosed with type 1 diabetes?
No, different question.
Okay. So again, I think anybody with any issues on the feet really depends on the extent of the neuropathy and the number of years with diabetes and the diabetes control. So I think to be on the safe side, the standard answer should be with calluses, corns, and warts. They should be assessed by a medical professional and chiropodist in the community that's trained in dealing with these, and advice regarding footwear, etc. There is always a concern with plantar's warts with people that are had diabetes for a while and have some aspect of peripheral vascular disease that being very aggressive with wart treatment can be problematic. So I think that needs to be taken into consideration.
We have an asker who says that chemotherapy has led to neuropathy in the soles of the feet, and now diabetes is complicating this problem. What should they do?
I think the 5 key principles would still apply. Once peripheral neuropathy is there, regardless of the cause, the screening is still essential. And if they already have established neuropathy, rather than the once a year screening and checking by a healthcare professional, then it would need to be, depending if they've had ulcers or not, every 3 to 6 months or even in shorter intervals. So basically trying to focus on that 5th principle, which is early detection. And so that if anything does show up, that it is addressed through either education, proper and routine wear of footwear, and so on. So the 5 principles would still apply.
Okay, thank you. Next question is can a lack of certain vitamins and minerals, essentially fatty acids, lead to dry skin?
I guess I'll take that. I'm not aware. I mean, nutrition, I think, and proper hydration is the biggest factor for skin. I'm not aware of any specific fatty acid deficiency, but I'd probably defer to a specialist in dermatology to address that question directly. I think that really fluid intake and just managing blood sugar and being the best you can with your lubrication is key to preventing these dry areas on your feet.
Thank you, Dr. Evans. I think that's a fine answer. And next question is regarding what was mentioned, which is urea or uramol okay for kidney patients for their feet?
Yes, that's not a concern for kidneys. I can see how the urea part of it is confusing, but yes, it's fine as far as I'm aware. Yes.
And final question, recognizing we are at 3 p.m. Eastern, is I have neuropathy and only see a chiropodist. Is this okay?
I just want to
That's a
say
good
not
start.
only a chiropodist, sorry, you're seeing a chiropodist, which is great. So yeah, I mean, a chiropodist is a professional who is equipped with all the skills needed to screen and identify whether you are at risk. And I think you are in great hands.
Yeah, I would echo that. We train a lot of chiropodists in our clinic. They come through and they go out with a lot of knowledge, and I have full confidence in their training and treatment of patients in the community, and their first eyes on, which is the best.
Okay. We've got quite an outpouring of questions, so I am going to toss a couple more if you folks are okay with that. So we have a question that is it safe to use Jublia, Jublia, for nail fungus?
I don't manage nails, so I'll refer to.
Okay, so Jublia is an antifungal agent for nail fungus infections, and it is got very good evidence for the best topical agent that's available. It is quite expensive if you don't have drug coverage, so that does preclude a lot of people from using it. It is best used for when it's part of one nail. If it's all the nails, you'll probably find it's not that effective, and it does take 48 weeks to apply to get a result. So it's not overnight. If you're really thinking about treating a fungus and it needs to be treated, you might need to use oral agents.
Okay, thank you. A question regarding the recommended treatment for plantar warts. Are lasers effective?
For plantar warts, we should have had a chiropodist here. For plantar warts, there's a number of different ways of treating those, and you really have to be nasty to a plantar wart to get rid of it. There are anything from surgical to topical harsh sort of chemotherapeutic agents that you can put on these, and burning agents. In terms of laser, I've not had patients go for laser because I don't think it would be covered.
Okay. And a final question is, if a person has a lot of deep fissure cuts on their feet, what is your suggestion?
I think this is similar to the first question of the afternoon about the cracks. And again, these deep fissures can be concerning, of course, and an entry for bacteria into the system. And of course, you can get a deeper infection. So they are openings of the skin we do need to take seriously, but they're a result primarily of, if there's not a primary skin disorder, then it's probably more related to the dryness. So, you know, I think it requires a healthcare professional to look at this. If it's dryness, I think we've discussed treatments with lubricants and moisturizers for the feet, and careful attention to doing that on a daily basis, avoiding the web spaces.
Okay, so thank you so much. And first of all, I'd like to say thank you to our guests and to our viewers for your excellent questions, and really hope that those were helpful for you. To our guests, we're nearing the end of our time here. I just want to close off. Before we do you have any final remarks or words of advice or encouragement for our viewers?
Well, for me, I would just like to say, I think prevention is the key for this, and a lot of patient engagement and education is what we need to do. I really look towards associations like Diabetes Canada and Wounds Canada to promote the care of diabetic patients across the country, try to coordinate this. And I know Wounds Canada is working on a diabetic foot pathway, which I'm hoping will help direct and educate care providers at all levels, and provide educations for the community and patients at large. So on a happy note, I feel optimistic that things will improve.
I'll ride that wave, and I agree. I think the future is bright. There are some great researchers, scientists, clinicians who are putting foot care at the frontier. And I think just a reminder to people that you are not alone. This takes a village. So don't take on more than you can or should, and know that there is a role for all of us to play here together. And it's a privilege to be working with you all, you know, living with diabetes and working on improved quality of life and better outcomes. And thanks for having me here. This has been a great space to talk about feet and prevention.
And I agree with both Robyn and Zaina. Prevention is key. It's the #1 thing we need to be focusing on. And as mentioned, it does take a village. It does take an incredibly large team with people living with diabetes being the leader of that team, people like Matt. So it's important, Matt, that you and others living with diabetes be your own advocates. Caregivers or people who are living with people with diabetes also act as advocates, and organizations like Diabetes Canada and Wounds Canada will continue to advocate for the best preventative care and the best treatment for people who do incur foot ulcers.
My best advice to any patients out there or anyone dealing with type 2 diabetes or type 1 diabetes and they get a foot problem is just address it right away. The more you are part of the team working towards healing that ulcer, the faster it will heal. If there's other aspects of your health in your life that you need to fix in order to manage your diabetes better, then fix it now. So you don't, like, I learned the hard way, and I'm realizing, okay, there's somewhat of a light at the end of the tunnel, but Dr. Evans is still going to be my best friend for a long time. But address it. Don't sit and wait. Don't think you're Superman. Don't have a complex, because I did that and it put me in a bad position. So don't wait. Address your issues and just work together with your care providers, and you'll end up with better results than if you don't.
Thanks, Matt. And I think you represent one of those very knowledgeable patients who's been through a lot, and I hope that our association will be less and less wisdom.
Yeah. I want to get to the point where I see every 6 months myself, but for now,
that's a goal.
Stuck together.
That's a goal.
Yeah.
Alrighty.
Well, thank you so much, everyone. And to be honest, I really appreciate the conversation that we were able to have today. And I am confident and I'm hopeful that the future is bright. And I'm also hopeful that all the answers and information you provided was truly helpful and impactful for folks watching and folks that will watch this in the future. So truly, thank you so much. I'm very grateful that you all made the time to join today. And to our viewers, please never hesitate to reach out to either Diabetes Canada or Wounds Canada. You can contact us at www.diabetes.ca or woundscanada.ca via email. Both of them start with info at that same website. So, you know, we have information and we can connect you with further experts, and I hope that you're left feeling a little more knowledgeable and empowered and optimistic after this webinar. So thank you to everyone, and be well. Thanks again for joining us.
Thank you.
Thank you.
Thanks.
Thanks, everybody.
Thanks.